Hello, everyone. I'm Lisa Graves, and I want to welcome you to today's presentation on the management of chronic pain in a diverse patient population with our presenter, Dr. Lydia Hatcher. A few slides as required for our continuing professional development. We want to acknowledge that we are in the traditional unceded and unsurrendered Algonquin Anishinaabe territory as part of acknowledging the land on which we are. We also want to acknowledge that for this presentation, it's been made possible through a financial contribution from Health Canada. Les opinions exprimées ne représentent pas nécessairement celles de Santé Canada. I want to have a special thank you as well to all of the members of the program's planning committee, whose contributions have really allowed us to develop a program that's interesting, exciting, and is bringing you some of the cutting edge information about how to do this. Attached are all of our disclosures. And there is, of course, a disclaimer reminding everyone about the limits to which we need to go in terms of participating in continuing professional development. And it continues on again. Lots of helpful information for you. There is live transcription to this session if you'd like to use that. Please continue to submit your questions through the question and answer function. We'll have a question and answer period at the end. And if anything urgent comes up, we'll address it in the middle. So keep those questions coming so we can have a robust session at the end. The session is being recorded. And so again, be mindful of that as we move forward. Want to again give you a little bit of a tantalizer and an appetizer for again our upcoming webinars in March, April, and in September, with again some exciting speakers on physician liability, chronic pain, and older individuals, and then a dip in the waters around advanced chronic pain management. So as we move on to the part of today's session that I know you're actually interested in hearing from, I want to take this opportunity to introduce Dr. Lydia Hatcher. Dr. Hatcher is a full-service rural family doctor, an emergency physician, and a full-time academic, and now has a specialty in pain management and psychotherapy. Her focus is on the biopsychosocial approach to pain management. She's a medical inspector for the College of Physicians and Surgeons of Ontario and works with the CMPA as an expert witness. She chairs a subcommittee for the National Opioid Use Guideline Group and was on the expert panel for the 2017 Canadian Opioid Guideline. She is president of the Canadian Academy of Pain Management and a member of the Canadian Pain Society and the International Association for the Study of Pain. She's a primary investigator at McMaster for several clinical trials and is an associate clinical professor of family medicine at McMaster University. I'm very much looking forward to Dr. Hatcher's presentation, and I will turn the baton over to you, Dr. Hatcher.
Thank you very much. I am just going to share my screen now. Okay, well, thank you all for coming. This has been a really interesting presentation to organize. As you know, this was developed with regards to modules for postgraduate students. And I've been working on this module for the first time in a really meaningful way with Catherine Lemise, who is a patient partner, a chronic pain patient herself. And the entire process was done with her having quite significant involvement in the style and content development. There's the acknowledgement. You've heard some of these before. My disclosure, you already heard Lisa say some of this. I do a number of lectures and talks for a variety of companies, mostly nonprofits. And you heard that some of the things that I'm involved with regards to my experience in pain management. And so I think I'll just move on from that. Everything that I'm going to tell you as best possible will be evidence-based, guideline-based, and if it's my opinion, I will identify that as such. And everything that's in the presentation has been reviewed in a larger sense with the planning committee that Lisa showed you already. So what I hope you're going to get out of the presentation today is understand a little bit about the settings and circumstances that you as a provider might be dealing with a pain patient in, both yourself and for them. And then talk a little bit about some of those needs of those chronic pain patients. Specifically, there's a section on substance use disorder, but a lot about determinants of health, and in line with that, a patient-centered approach. And then finally, some legal, social, and bioethical issues in the settings that you might find yourself in. The module is divided into 5 sections. And the first one is a discussion about some of the different clinical settings that you might find yourself in. Chronic pain is extremely common. 1 in 4 patients will have some kind of a chronic pain condition. The common ones will be low back pain, OA, headaches, post-surgical, many, many others. This year, Stats Canada said that 20% of the Canadian population is now over the age of 65. I'm happy or sad to say I'm in that group. Consequently, it's going to increase the cost and concerns about pain management. And you can see here that in Canada, the direct and indirect costs are in the billions of dollars per year. So where might you find patients with pain? So where are you, and where would those patients be? So, it can be in your office, and your office can be in any of the wheres that you see on the right: remote, rural, suburban, urban, or virtual, which of course, with COVID, many of us have moved to using very frequently. It might be in a hospital setting, it might be in a nursing home, it might be in the emergency department, it might be street with homeless people. And it might be custodial care, which can involve a variety of different places, everything from prison settings, closed custody facilities, and other kinds of custodial care that patients may find themselves in. And depending on that environment, your ability to respond and manage those patients is going to be different. So we thought it was important for people to think about, where am I actually seeing patients and where am I practicing with those patients? And then thinking about those environments, what resources do you have in that environment? The number one, of course, is yourself as a care provider. And that means that you have to develop and have a knowledge of pain management. But for many physicians, and having been a remote and rural family physician for decades, I often would look at myself and be the only person who had some expertise. And then the next in line would be my colleagues. And that might be other family doctors who you could ask for advice. It might be specialists that you'd contact via telephone, email, or the various ways, again, in the area you practice. And it might be people you're working with: nurses, nurse practitioners, physician assistants, and maybe others, even your staff, who might be able to give you advice. It might be allied health professionals, of which there are a variety, and I haven't listed them all here: occupational therapy, physiotherapy, social work, psychologists, pharmacists. And pharmacists in rural areas can really be very useful in a variety of ways, which I'll talk about a bit more as we go through the presentation. What programs are available in your community? And you should have an awareness of some of those. GYMS, the Y, are there community-based programs, faith and cultural organizations in the community? What is free and what do patients have to pay for? So when you're explaining to patients what's available, you have a bit of a sense in their environment of what that might be. But then what are the barriers to accessing some of those resources? Well, the number one is probably the cost and affordability of care that you may be providing or that may be available to them. More specifically, coverage for things like medications, any kind of therapy, whether it's physiotherapy, but any non-drug therapy. Can the patient afford it? What drugs are available that they can afford or that would be covered? Travel and accessibility, another very important issue. In an urban area, it might be getting a bus, it might be getting transportation for disabled patients, but it might be remote access. And again, when I worked in Goose Bay, we had patients in communities that were even more remote that you would require an airplane to go in and get access to. Boats, etc. So it can be as varied as you can imagine. Timely access is huge. It's huge in Canada. We all know some of the problems with wait times. And that's where using things like your colleagues to help you can be really useful. Whenever I give a presentation, I always say to people, here's my email, call me. Even if it's not a patient, I'm not in your practice area, I'm happy to give advice. And I think most physicians are of that same mindset. But there are mentoring programs that are Canada-wide. Project Echo, which has been developed mostly in Ontario for pain management, but they certainly have a lot of satellite settings across Canada. The Atlantic Mentorship Network is still active, and that's obviously for Atlantic Canadians. And there may be other local programs that are available in your area for mentorship in the chronic pain world. So that's kind of the first section. The second section that we felt was really important to discuss with yourself and with patients is managing pain early. As a practitioner of chronic pain, one of the things that we see problematically is patients that have been waiting a long time to get help with their pain issue. And we well recognize, and in fact, anesthetists have probably been in the foremost of dealing with this issue, is how do we manage pain before it becomes chronic? Because then you solve a lot of that problem. And so the number one is addressing acute pain management early. So that means if you've got a soft tissue injury, if you've got a fracture, dealing with the pain in a competent and effective manner that makes it less likely that they'll go on to have chronic pain. And that does include things like giving very short amounts of pain medication and reassuring patients that after that 2 or 3 days, they can usually manage with over-the-counter therapies. Using a patient-centered focus, and I'm going to talk a bit more about that in a moment. And then making sure if that patient has mental health disorders or medical issues that may exacerbate their pain that are pre-existing, that you try and help deal with those at the same time. Because if somebody has a severe anxiety disorder, as an example, and now they're more anxious about their pain, dealing with that anxiety may help them deal with their pain better. So how do you do that? Well, you have to assess what strategies those patients are using at that early management. And so, there are sort of 6 techniques that we suggest that you think about. The first one is, what is the mood of the patient? There may be anxiety about the condition that they're suffering from, but there may be other issues. It might be depression. It might be other issues around mood that's problematic for them. Have you explained to them about pacing, not overdoing it, not doing that sort of weekend warrior type activity? Do they use relaxation techniques? Do they understand any? Can you teach them any quick ones? And we go into some detail in the modules for the students about specific techniques that they can consider using. Are the patients active? What kind of activity? Are they very physically fit? Are they runners? Are they patients who do regular exercise? Is their activity going for a walk in their walker down the corridor of their nursing home or in their apartment building? And what activities can you advise them about? What about passive versus active coping? Can we move them from that more passive, do this for me, do that for me, into helping them to cope more actively? And I'll talk more about that again. And what are their beliefs and fears? We often will hear a patient saying, oh, the doctor told me I'd be in a wheelchair in 10 years. And oftentimes that's not really what was said. It's just the patient's interpretation. So if they have beliefs and fears, and I'll give you a really common one. How often have we inadvertently said to a patient, oh, you've got degenerative disc disease in your back? Well, if I told any one of you who are sort of my age, you've got white hair disease, you've got saggy boob disease, you've got wrinkly skin disease, we'd laugh. Well, degenerative disc disease in the spine is no different. It's just normal aging. So we have to be cautious about the language we use with patients so we don't give them fears and beliefs that are unacceptable. And they may have heard those things from family and friends, the internet, that give them fear about things that aren't necessarily factual. And one of the ways, and again, we teach this in medical school, we teach our family medicine residents to use the 5 techniques. What are the feelings? What are the patient has about their condition? What are their ideas about it? How are they functioning with that? And what are their expectations? So using that approach can really be helpful to find out where patients sit again. So we are using that patient-centered approach. And then we come to a different part of that early management is some of the factors that are implicated in the development and persistency of chronic pain. And these are mostly non-modifiable. So I'm going to talk about those first. And probably the most important one is adverse childhood events. And these can be psychological or physical events which have had a negative impact on the experience of not only pain, but their life experience and risk for chronicity. And we're probably all familiar with Maslow's hierarchy, which looks at those chronic childhood events that happen, whether it's trauma, can be simple things like a divorce, abuse, you know those, that lead to higher risk of chronic disease, that lead to higher risk of substance use disorder and other negative poor coping skills, decreased function, and early death. So huge amounts of research in trying to help people who've had childhood adverse events become more resilient to prevent that hierarchy of early death and decreased function. Cognitive factors I've alluded to already, the prior experiences and expectations of therapies. If they think something's going to be negative, it's more likely to. A lot of work with this using surgeries, total knee replacements is a good example. If people have had negative experiences of pain, they won't do as well following a knee replacement if they don't get intervention from psychologists and social workers to allow them to understand the healing process and the post-surgical outcomes. Post-chemotherapy, and chemotherapy in a very broad sense. We tend to think of chemotherapy as cancer therapy, but in fact, HIV chemotherapy, huge problem with development of neuropathic pain. Absolutely with cancer chemotherapies, but there's many other drug therapies that will cause pain following that can be very long-term. Genetics, our phenotypes. This is newer research, very exciting research. I do a lot of pharmacogenomic testing in my practice for patients that help them to understand what their genetics might be, both for substance use disorder, but also how they metabolize medications, and that's pharmacogenetics. We can't change these, but it's going to be useful as we move forward in managing patients more effectively, not only with pain, but a variety of medical conditions. So to keep with that thought of those early events in childhood and those events that people have had over their lives, a really interesting question to consider asking your patients: how do you connect your experience as a child, when you were younger, while in combat, in your home country, with the accident, the surgery, with how you are feeling, coping, and managing now? So you see how this one question in that patient's personal milieu can really help you as a practitioner help understand what it is that patient is thinking and feeling, and helping you understand how it's making them feel, manage, and cope at the present time. So a really important question that can give you tons of useful information in moving forward with managing a pain patient. So what we did with the development of the module, we developed a case of a patient with chronic pain that you can sort of take in a whole variety of settings and possibilities. So 36-year-old male, mixed race, back pain due to lifting at work. There were no physical red flags, no investigations needed. But now he's not working in his job. He is back at work, but doing sedentary work. He's depressed because he's not overly happy, and he has been using opioids that have been prescribed. And I would just like you to take a moment to think about the concerns with somebody like this in your practice. So one of the things with somebody like Juden that you might think about, and very important, is again that partnership that you and the patient develop to think about an appropriate action plan for him. It's something that the patient should want and that you think is also reasonable for that patient. It should answer the questions: what does the patient want to do? Is it an activity? Is it a return to work? Could it be weight management, smoking, opioid cessation? Smoking cessation, opioid tapering. Could be any one of those things. How much? Start with small wins. It might be a very small decrease in the amount of opioids we want the patient to taper, if that's where we're going. When do you want to do it? Do you want to do it now? Do you want to start? And the pandemic is a great example. I had patients who were doing a really, really nice slow taper. The pandemic happened, anxiety levels rose, virtual care, not able to do urine screens, not able to see the patients. Maybe we pause and wait. And how often is that patient going to do the what? So once you've identified those things and you feel that, yeah, this is going to be a win, then go ahead with that. And they should be small things that you feel very confident that the patient is going to be able to do. And I'm sure you're all familiar with SMART goals: specific, measurable, attainable, relevant, and timely. And then the goals you develop with the patient should really follow within that SMART goal action plan. And you might write it down for the patient, but it's something that you can come back to when you see the patient next and ask them, did we do well? And if you do, then you can really give the patient lots of positive feedback, which we know is really important for patients. So then section 3 of the module looks again at managing those diverse needs and barriers to care in chronic pain. And so one of the things, if we go back to think about the last 2 slides about self-management, is what's the health literacy of your patient? How do you communicate effectively with them? Is their hearing good? Is their vision good? And that's potentially most important for older people, disabled people, but it could be anybody. Language. What's their first language? Is it your first language? What is their literacy skill? What level of education have they had? And there are many patients who don't want to tell their physicians that they are illiterate. And so be very cautious as you sort of speak to patients that you're speaking in a level of language that they can understand. We typically say grade 6 or lower should be the literacy level that you use with all your patients. So, using a word like bowel movement, they may not understand that. You might need to use words like poop, or, and I often say, think about how you'd address things to an 8 or 9 year old child, and maybe we should be talking to everybody like that. Provide print and picture instructions. And again, the print should be always at a grade 6 level, and if possible, in their language of origin. If you feel, or if they tell you that they're not that competent in speaking the language that you speak, consider using translators and system navigators. And those translators should typically not be family members, because if you think about all the potential risk of and concerns with a person's personal environment, using a third-party translator has been shown in research to be much more effective. And system navigators can help them figure out where they need to be in the system and be very supportive. Personal patient safety. In the pandemic, I had patients who became very, very unstable in their personal environments. It may be living with a spouse that there were issues with. The phone actually was incredibly helpful. I could have a conversation with the patient to say, are you comfortable speaking to me in the present environment? Answer it yes or no. They could say no. Is there a place you can go where I can speak with you safely? And let's organize our meetings, our phone calls in that environment. And it worked really well with some of my patients. So just thinking about those things as you're dealing with your patients. Cultural factors, so important. There's many patients who are in environments where, for instance, cannabis is absolutely taboo, alcohol taboo, from the cultures that they find themselves in. And to some degree, mood disorders are taboo in certain cultures. So being aware of how a patient may perceive you saying, well, you're depressed, or, you know, you're doing this, might it is difficult. So being aware of what their cultural factors are, and then cultural safety. And we spent quite a bit of time in the module dealing with this. It is such a sort of a topical discussion in the world that we live in right now. But having an awareness of that, using humility in your practice. It's difficult sometimes for us to not say things to a patient that we may perceive as joking, but it isn't. And to some degree, even gender is, you know, we can be insensitive about those things. So having the sensitivity and being culturally competent. And there's many great programs on developing cultural competency, and we do have some of those in the actual module that students can look at and work with. Another part of that chronic pain picture for patients is this huge circle of cardiometabolic disorders that can be everything from medical conditions to physical conditions to psychological conditions, and everything in between. So just a few of the things that we talk about here is making sure for your patients who might have, I mean, I've got patients who are on 25 medications when I see them for the first time, you know, for their diabetes, for their mood, for their cardiovascular conditions, their hypertension. You've all got those patients. If you can, get a med reconciliation done with a pharmacologist. Consider deprescribing if you can. Do the patients have mental health supports, and can we provide those for them? Use allied health professionals to help you as a provider. They can be so resourceful for you. And are there community resources that you can use for patients in that setting? So then we come back to Juten again. And considering some of the time constraints that we have, you know, as family doctors, you know, I can't speak for all of you, but 6 people an hour is not uncommon in primary care. You know, are they in person? Is it virtual? These are all concerns that are big at the moment. And so I bring up Juten again. He's doing desk work. He doesn't like it. He's sitting for long periods. He can't exercise because once he finishes work, he comes home. His wife is working evening shifts, so he's looking after the children. He's gained weight. He's feeling depressed. He's not sleeping. Well, how we pose this to the students, but what is one way you might consider managing? And of course, for many of these questions, there's multiple answers to that. You might consider using some tools to ascertain how depressed he is. If his wife has, or he has, does he have an employee assistance program he can utilize? Is there counseling that you can offer either yourself or in your environment? Does he need a referral for other specialty care? So these are all things that you might consider, and they're all correct. Well, what about some of the modifiable health determinants that you might see in your patients? Again, I've just mentioned mood disorder assessments tools, pre-existing mental health issues. These are huge with chronic pain. And I think it's very rare for chronic pain patients not to be down. They may not be completely depressed, but as a chronic pain patient myself, Catherine and I discussed at length how we felt over the years with our chronic pain conditions, how it feels to be getting older is a concern. You know, again, is medication something that we can manage in a more effective way? And, you know, is there counseling that can be done? And I specifically wanted to show you the slide on acceptance and commitment therapy because it's a very common tool we use in the pain world, but it may not be something that you're as familiar with as primary care providers. But it is a really quick conversation that you can have with a patient in any of the settings that you can find yourself in. And it kind of goes like this. This is who I am. and I'm okay with it. And I can tell you, I've had both my knees replaced. And when I was a runner, I was a very physically fit person. And I would, for a long time, about 2 years, and as a pain doctor who practices this, I would see runners and I would be angry with them. I'd want to hit them. I'd want to smack them. I felt that way as I saw them. And I realized, like, this is not a healthy thing. Reduce the tendency to wish for the pain-free past and try and do the best with what you have to work with as you are now. This can be really difficult for patients because they can spend a lot of time thinking about how they were before. Try and allow thoughts about your condition to come and go without struggling. Try and replace the anger and resentment. And it's challenging. It is challenging. But what are the values that are most important to you now? What is it that you actually want out of life? And for the lady in the picture I show you here, it may simply be to have the human touch, to have companionship. So setting somebody up with friendly visitors might be all you need to do. It might be seeing her family. It might be doing Zoom calls with relatives. And what are the goals according to those new values? What is it you want to do that will make it better for you? So finding this out and trying to find some commonalities for the patient can be really important in their quest. So non-modifiable health determinants. These are things that, again, we can't really change, but we can enhance function for our age, our gender, our sex, our genetic differences, our race and an ethnicity, previous things that have happened to us, or the injury itself cannot be changed, and the pre-existing conditions that we have. But what we do want to do is try and have patients do things that will improve their function by considering consistency in their routines, improving their sleep, improving their nutrition, and enhancing their activity. So we were asked to develop one of the submodules specifically with substance use disorder with chronic pain. It is a huge part and concern in the pain world. And, you know, I think with the opioid crisis in this sort of the 2015, 2016, it really got brought to the forefront. It was where we got the funding to bring forward the 2017 National Opioid Guidelines. And a lot of this section will basically say, go to those guidelines, use tools to assist you in managing this particular piece. But the behaviors that typically identify substance use disorders typically include craving that substance, loss of control of use of the substance, so you're not able to control it, compulsive use. So even though you may say, I'm not going to do it, you may be taking extra medications, having that extra drink, eating that extra food, gambling when you know you don't have the money, whatever the substance use might be. So you continue to use it despite the harms. Are there difficulties and precautions of diagnosing substance use disorder? Absolutely there are. And, you know, you as a care provider are not able to effectively always manage that, but being aware, understanding what substance use disorder means, using the DSM-5 will help you. And again, we introduce people to the national guidelines and the other tools that are associated with it. And then I'm going to talk about boundary setting. So to come back to Juten again, and this happens in real life with patients, right? We find more out about them as we develop that long-term relationship with them. And so in discussing with him, you may discover that he did use substances, stopped when he had children and decided, I've got to be good. But occasionally at parties, somebody's got some, he uses it. And unfortunately, what he has been doing recently is taking opioids from a friend to help his pain. And this, of course, can be incredibly dangerous depending on the source. So the question that we ask the providers, and I would ask you to think about yourselves, is how would you approach this? What are you going to do with him? And these are some of the things. Use tools to help assess early on in the patient care. And ideally, you would use this tool before you make a decision to start somebody on a long-term opioids, if you're ever going to do that. And there are other risk tools you could use, KJADE and all sorts of tools to assess substance use. You need to assess these patients much more regularly than you would if somebody's got high risk behavior, and you're going to use tools from the 2010 and 2017 guidelines, the 6A's, and the opioid manager, of which the 6A's I'm going to show you. So the 6A's include basic tools that most of us would know. Of course, we have to do this while we're assessing patients, but as an inspector with the college, doesn't always get done in the most effective manner. So make sure you are doing an assessment of their affect. What's their mood like? Their analgesia. What's their pain like? Is it being managed well? Are you actually getting benefit from the therapies? Their activity, I've talked a bit about that already. What are they doing? Is it effective? Are they overdoing it? Are there adverse effects that they're having from the medications that they may be taking, or from the therapies they may be doing, or no effect? Is there aberrant behavior? What is it? Document it, and for goodness sake, tell us or tell yourself, what are you going to do about that? Keep an accurate medication record, amount, route, frequency, all those things, what the drug is, and document your findings. Follow the guidelines, and if there is substance use disorder or opioid use disorder, make sure that you are documenting that you're managing it and that you actually are trying your best to manage it. Set boundaries for patients, especially if substance use becomes obvious during your management of the patient, or it was there previously. And this is true with almost any medications that you might be using, because patients who have substance use disorders potentially are more at risk even for taking the classic one. Oh, instead of the 6 to 8 days of over-the-counter extra strength Tylenol, they're taking 12 or 20 a day. And, the liver risks are concerning. So treatment agreements, don't have to do them with everybody written, but that may be your practice. You may decide to do that with everybody, which is totally reasonable. If you're dispensing controlled substance, start with very small amounts. Just give a week's worth and explain to the patient that this is just a trial. If you're going to do long-term usage, plan for how that's going to look. Plan for how you might stop doing that if it's not effective. Legacy patients, a different kettle of fish. We've got many patients on high-dose opioids. I literally read an article this morning from the Pain Journal that does talk a lot about the harms that we've done to rapid reduction and reducing patients against their will without using that patient-centered approach. So please, 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 with your legacy patient-centered. And if you have anxiety about, but the dose is so high, that's where calling colleagues, it's where invoking specialists who can advise you and give you advice, and documenting can be your best friend. Urine drug screens, routine use may be part of your practice, but it's quite controversial, and we discussed that in the module. It absolutely has a strong place to play in substance use disorder management, but the use of it for pain management is far more controversial. But make sure that if you are doing them, and there is a place for doing them at least once, probably annually for patients, and maybe at the beginning of therapy, but make sure you're managing the results effectively. The studies show that about 30% of patients will have an aberrant urine drug screen, many false positives, and many false negatives. And again, we can talk about those in the chat if people have questions, but be aware that there are those. So the last section is sort of quite different from the rest, in that we talked a lot more about managing bioethical, social, and legal issues in chronic pain, with sort of 4 little areas: unacceptable patient behavior, which is the biggest, and then some of the healthcare systems and provider factors that are a concern, medical legal issues, and end-of-life pain care. So I'm going to go over each of those. So we've all had patients who've had unacceptable behavior in our office, regardless of whether they've got pain or not. Might be being rude or abusive, not showing up for appointments that they're booked for, being late. It may be aberrant drug behavior. It can be things like prescription fraud, reporting lost or stolen medications that may or may not be factual. I cannot tell you how many patients who get a police report and, because anybody can call in and say, oh, my house got broken into, they can tip over a piece of furniture and get the doctor to then prescribe more medication, even though there wasn't truly a break-in. And there can be threatened or actual violence. And you consider looking down at these, that they get more serious as we progress. And when you get these behaviors, be aware that the first thing you need to do as a provider is to be calm and non-judgmental. It's quite easy when the patient's upset and angry and their voice is raised to do something called mirroring, where you start to mirror the patient's behaviors rather than staying calm, being non-judgmental, which will calm the patient down. So if I'm talking to you like this in a calm voice, you sound upset, let's sit down and talk about it. The patient's much more likely to calm down than if you say, sit down and behave yourself, which we could do. And we really do have to stop and take a breath ourselves. Are there alternative explanations for the behavior? Maybe there's food insufficiency, financial insecurity, housing insecurity. We see so much of this with the pandemic. So make sure we understand where the behavior is coming from. And that's where you can use that Fife technique again. You want to work with the patient and explain that to them. I'm here to help you. Let's see if we can figure this out. But be sure to set boundaries with the patients, because for certain types of patient personality disorders, they will break those boundaries frequently. And we do talk in the module more specifically about how to respond to some of those personality disorders that can be difficult for you. So let me come back to Juten once more. And again, these are questions that we've asked the participants. What would you do if he comes in, he ran out of meds early, he's taking more on his work days, he is back at his regular job, he's on an antidepressant, his urine drug screen is concordant. What might you do? Recognizing we've got the history of the cocaine addiction and the occasional getting them from friends. And so these are possible answers depending on the patient and yours environment. You might increase his dose. You might add in other medications. You might want to taper him off opioids. You might refer him to a pain clinic. You might fire him as a patient if there's very egregious behavior. You might discuss with a colleague, and there may be other approaches. So there's no right or wrong answers. These are just options that in your milieu you might use. And what about some of the other factors that can lead to unacceptable behaviors, even in yourself? Well, burnout, huge. Overwork, lack of communication, which could be between you and other providers, you and the patient, inexperience. And I think we all experience that with virtual care. None of us had really done this in this way. I remember when we had the lockdown, I was calling everybody on the phone and I'm thinking, how do I get urine drug screens on my high-risk patients? I have no experience with that. And then uncertainty. I'm not sure if I am doing the right thing. I'm not sure if this is the thing that's good. Healthcare system causes cutbacks. We've all experienced that. Productivity pressures, siloing. I know what I'm doing, but I really don't know what goes on when that patient goes to that pain clinic up the road there. Racism, structural and systemic. We see that in the hospital systems in so many ways. COVID and social media, and we've seen the negativity around social media with the whole anti-vax issue. And so, all these things are playing into some of the factors that are really affecting our mental health for us as providers. And then medical legal issues, managing prescription fraud. I think with electronic prescribing, that's made a huge difference. But be cautious in your prescribing. B, don't give handwritten prescriptions to patients. Don't overprescribe. Don't give large quantities. Work with your pharmacists. We in Ontario do have the narcotic monitoring system. Many other provinces have similar triplicate prescription programs and the like. Use those databases if you have capacity to do so. And be aware that your patient can still double doctor. Again, if there's narcotic monitoring, it's harder, but it sometimes also can be a mistake. I've had patients who've gone and had a surgical procedure. The surgeon just gives them a prescription, and then they call me and, Dr. Hatcher, I didn't know what the drug was. When I got to the pharmacy, he told me it was an opioid, and I know I'm not supposed to. They're nervous about it. You reassure them that they did nothing wrong. So again, but it still is perceived as that. What about discharging and firing a patient? Hopefully it's something we hardly ever have to do. I would always suggest that if you have a patient that's been egregious, unless it's like if a patient is violent with you, you may make a decision quite correctly that that's it, you're done. You call the police. They may be charged with a criminal offense, but there may be times when you really do want to go through what we call that natural justice, where we allow the patient to tell their side of the story. Follow-up actions, what are the alternatives? If you're in a remote rural area, you may have to keep the patient on. You do not have to keep prescribing them controlled substances, however. And how do you manage your fired patients? And the college websites are quite clear, as is the CMP, about what you do when you are firing a patient. And finally, medical legal issues. We have responsibilities to care for patients on opioids. Family doctors cannot say, I don't prescribe. It's in the scope of our practice, unless you don't have a license to do that. Be aware when you're speaking to legal authorities what the privacy regulations are, who is allowed to speak on the patient's behalf, and if required, that a court order has been provided. If a patient's records, or if you're asking to be released, make sure you have the appropriate permission. And if you're not sure, call the CMPA and get their opinion first. Don't put yourself in the state where you'll be harmed. And then finally, end of life care. And I added this in simply because chronic pain has now been considered an option for MAID. It is considered a grievous and irremediable medical condition, and we have had multiple conversations with our MAID team in the McMaster Hamilton area about how do we manage patients. If you aren't comfortable, you do have a responsibility to refer. It must be managed. You can't just say, well, if that's what you want, we're going to do it. That's inappropriate. And then think about palliation and all sorts of many other, again, requirements around that. So I do want to finish with thanking Catherine again, who has worked with me to make sure that we've thought about the patient through all of this. She's done in the module, we did a couple of patient scenarios where she was the patient and I was the doctor, and we worked well together. So thank you. And I'm going to stop sharing right now and take any questions. So Lisa, you're muted, but I just have the Q&A opened. The first question is, the ORT has been shown to be non-predictive in the CDC 2016 guidelines. It is a guide. It is not a predictor. Somebody can be low risk and have substance use disorder, high risk and have none. Absolutely. The next question, do you think that practitioners who treat chronic pain should know how to treat opioid use disorder, specifically with buprenorphine or slow release oral morphine, if not methadone? I do think yes. For those of us who are in pain management, it's certainly part of my practice, and we certainly teach this to practitioners. And in fact, the Canadian Academy of Pain Management, we have got a webinar series, and I'm actually teaching low dose buprenorphine use for patients who might consider tapering or coming off opioids. So if people want information about that, contact me afterwards. And then the third question is, what are your thoughts on social pain? Some patients make analgesic. Yeah, I think we're seeing a lot of this with the pandemic, and you know, treating, you know, to use that term, social pain. I think a lot of people, you have used alcohol. If you look at the alcohol consumption during the pandemic to treat the pain of being alone, the pain of uncertainty, the pain of the challenges. I think that's where getting psychological help is so important. And again, I can speak more to that. And then one of my colleagues, Dr. Norm Buckley, has asked me, can I please reiterate your comments about the issue of forced tapering? Very important. Yeah, so when the 2010 guidelines came out, and many of us had patients on thousands of milligrams of morphine equivalent, not for potentially the best reasons, but at the time it was the norm, no pun intended, norm. You know, most of us tried to bring the patients down closer to that 200, probably way too rapidly. And if you go back and look at the statistics, and the article I just read this morning looked at 14,000 patients that have been tapered off opioids, and they found a 28% increase in suicide, a 40% increase in substance use disorder, often going to the street, 10 or 11% increase in overdose deaths from people using using heroin instead of opioids. It's a huge problem. So if you have patients on higher than 200 morphine equivalents, or even higher than 90, as the new guidelines suggest, talk with them. Nobody from the college is going to take your license away by managing them effectively. So I really, really, really want to stress the importance of not forced tapering, and being forceful with third-party providers like workers' compensation organizations and insurance companies, who frequently send letters saying, why haven't you done this? There's really good research to explain that as long as you're managing effectively, doing all the right things with your 6 A's and using the opioid manager, using the appropriate tools, that you are managing your patient effectively. Dr. Guzman, for patients with chronic pain who are using high-dose opioids and continuing to have pain with side effects, what's the best approach for pain management in my experience? Yeah, in an ideal world, bringing them down to lower doses. But the other things, sometimes doing an opioid rotation, making sure you're thinking about other medications that you might utilize instead of, switching them to things like Suboxone and Methadone for pain. And they are very different types of prescribing than for substance use disorder. So the Methadone is usually TID, QID, oral pill dosing. The Suboxone is again often BID or TID dosing. But these can be excellent choices instead of the high-dose opioids that have worked quite well. They do tend to work better for neuropathic pain, but there are options. And again, bringing their dose down very, very slowly with a taper can often be very, very useful. Yes, Lisa, I can get that paper to you. I literally just read it this morning, but I will do that. And it's in the journal Pain.
Sorry, Jolene, did you want to unmute and ask your question?
Oh, sure. I work in pain and addictions, just new as of the last year. So I'm training and working with a lot of people. And I had a very bizarre situation, and I've learned about rules in my province in talking with the College of Pharmacists and now the prescription monitoring program, that there is no law that a child, a minor, like in this case, it was a 13 or 14-year-old, can't go to the pharmacy and pick up a prescription, an opioid prescription. And I just wondered if there is any other law, or if other provinces have rules around this. It was a bizarre situation. The child wasn't my patient. The parent was my patient, and they had signed a sheet of paper for their kid to go pick it up, and the pharmacy dispensed it. And so I'm still following up with all the levels of investigation to try to get the situation fixed. But in doing that, I've found out that there aren't any laws or rules,
So
and it
an
didn't get flagged.
emancipated minor is able to pick up their own prescription if it's a prescription for them. So an emancipated minor is typically somebody between the ages of 12 and legal age, depending on the province, who has been usually court designated as being able to speak for themselves. I'm presuming that is not the case with this patient. It is interesting. And I'm not sure I have an answer, Jolene, for you, except to say that it'd be a great question to bring to the CMPA, because they may have some legal precedents that they could advise you about with regards to children picking up a prescription that is a controlled substance.
Even just what you said, that emancipated minor is really determined by the court. The pharmacist can't just decide that. That alone is good information and a good point that I didn't really think about. Yeah.
So yeah, my typical go-to when I sort of have an issue that's difficult to deal with is the CMPA usually is the voice of wisdom. And I know Sue Swigum is doing next week's webinar, but Sue was a great source of wisdom from a CMPA perspective as she worked with them for years. We've got a couple more questions. Are you able to speak to the non-DSM diagnosis of complex persistent opioid dependence? Yes, I can. Probably a talk in itself. And so if you actually look at OUD in the DSM-5, it very clearly states that the last 2 points, which is withdrawal and tolerance, are not part of OUD in an opioid prescribed patient. So if you remove those two things, you really end, so that puts opioid use disorder in that sort of 4 C's place. And then you've got the patients, and again, I'll use the term, the legacy patients are on high dose opioids that frequently will do things like take their medications more frequently than they should. They're often using over-the-counter Tylenol 1s in high doses. And they're really a challenging group. And they will often be honest with you, tell you, I'm not doing any of these other things, and their families will support. No, they're not. And using the trust that we have to have in we have to trust our patients when they are telling us things. They may not be truthful with us, and that can be a hard pill to swallow. So I think that for me is kind of the difference, is that these are complex patients, often with significant comorbid psychological aspects to their care that make it difficult. The anxiety patients, the borderline personality, the patients who have other substance use disorders, it can be very challenging. But I don't have a solution except to say that I think that would be how I would conceptualize the gray area, is that, there's the very clear OUD, and then there's everybody else who it's not so clear. Let's see, we've got one more question from Irina. Please comment when patients are on Suboxone, what's important to watch for long term. Yeah, some of the things, of course, is if they have acute pain conditions, and again, a lecture in and of itself. But you can actually, if somebody's on stable Suboxone, you can add in regular opioids. You will need higher doses that can be used for breakthrough. So we do that. Long-term Suboxone, it's not nearly as dangerous as methadone, and the QT is not such a problem. And Irina, I don't know if you have wisdom to add to long-term Suboxone issues. Most of my pain patients have not been on it long-term because it's something we've really started doing in the last 5 years. But it does work well, and the biggest thing is patients not tolerating some of the side effects, which would be true with most of the other opioids.
So I'm going to close the discussion right now, even though I hate to do so, because I think we could probably go on for another hour or so. Thank you, Dr. Hatcher, for a wonderful presentation and for clearly engaging all of us in your work and in the question and answer session. I want to remind all of the participants as you sort of log out, there is going to be a post-program survey. We value your feedback as we work to create this community of practice around chronic pains, opioids, and substance use. Certificates will be available for the entire program on October 3rd. And the session has been recorded. And if you'd like to take a look at the session recording, it'll be available on the CPD Program Center in about a week. So thank you again for your active participation. And thank you, Dr. Hatcher, yet again for a wonderful presentation.